Thank you very much, and thank you all for being here, and thanks to our wonderful hosts in Vancouver, Julio, and all protocols observed. So I'm going to talk about HPTN 065 and the lessons learned from this study. So the purpose of 065 was to determine the feasibility of the test, link, and treat strategy for prevention of HIV transmission in the US. And why is this important, and why should we pay attention to the lessons learned? Firstly, I think people forget, but the US actually is the country with the 8th largest number of people living with HIV in the world. Importantly, all of the studies you've heard about thus far are being conducted in generalized epidemics. So all of the treatment as prevention studies are being conducted in sub-Saharan Africa. And there are many countries around the world where the epidemic is largely concentrated epidemic, and there are also more and more countries with generalized epidemic that are facing pockets of concentrated transmission. So it's relevant for us to think about how we're going to tackle and try to achieve this in the context of a concentrated epidemic. So HPTN 065 had several components that are on this slide, and each of these components was really targeted to the HIV care continuum. The first component was to expand HIV testing through social mobilization and universal offer of HIV testing at health facilities, hospitals. The second component was focused on linkage to care. The third component on viral suppression. And then there's a focused intervention and prevention in positives for those identified to be positive through the HIV testing endeavors. And lastly, there was also a component of provider and patient surveys. We could spend many hours talking about lessons learned from each of these components, but today I'm going to focus on the lessons learned from the two components, the linkage to care and the viral suppression components, because we utilized an innovative structural intervention financial incentives for those components. So what were the objectives of this part of the study, this component of the study? Was to determine the feasibility and effectiveness of using financial incentives or cash transfer on linkage to care of HIV positive individuals who test positive at HIV care sites within 3 months. And the second part was to look at the effectiveness of and feasibility of financial incentives on viral suppression, and defined as less than 400 copies in patients in HIV care. So where was the study conducted? We selected 2 communities in the US, in the Bronx, New York, and Washington, D.C. to conduct the study. These are 2 communities that are severely affected by the HIV epidemic in the US. And the study was, we recruited 38 sites in the Bronx and similarly 38 sites in Washington, D.C., both testing as well as HIV care sites. And these testing sites and care sites actually represented the vast majority of sites, the sites that had the largest number identified with HIV infection and also that had the largest numbers of patients. So we wanted to achieve coverage in those communities. These sites, the testing sites and the care sites, were randomized to financial incentive versus standard of care. Quickly, so at HIV test sites that were assigned to financial incentives, anybody who was identified to be HIV positive received a coupon. When they took that coupon to a care site, within 3 months, had to be within 3 months, they'd get a $25 gift card for just getting the test done, and then another $100 gift card to get it after they had an encounter with the provider and developed a care plan. For HIV care sites, they were assigned to financial incentives. Patients engaged in care and who had viral suppression, they received a $70 gift card, and a maximum of 1 card was given every 3 months. So this was a site randomized study. It was not an individual randomized study. And the amounts of these financial incentives were arrived at after very long consultations with many, many stakeholders. So there's several but key outcomes. One is linkage to care, as I expressed before, as defined, viral suppression overall, and then we also looked at viral suppression at the peak of the intervention, 18 months at the start of the intervention, and we looked at subgroups that were predefined, and we also looked at another outcome of interest, the effect of financial incentives on continuity of care. So another novel part of the study was assessing the outcomes through the use of the US surveillance system. And I don't know if many of you are aware of it, but it's a very robust system where testing data are submitted to local health authorities into the surveillance system. And we used those to determine the numbers of the people who were identified to be HIV positive. And also care sites, people who are in care, their data are submitted from these sites and from laboratories in the US that include the name, date of birth, Western blot findings, as well as every CD4 and viral load is submitted by the laboratories to the local health departments. And we utilize these data in collaboration with departments of health in these jurisdictions, as well as with support of the CDC to come up with our findings. Briefly, just quickly, the linkage to care, when we looked at the effect of financial incentive versus standard of care, we did not see a significant effect of financial incentives on a linkage to care. Probably we had smaller numbers of people identified positive than we had anticipated. Now, in terms of viral suppression, this was a huge effort, a total of 19,000 patients in care, and a total of almost 40,000 gift cards were dispensed. So what were the findings in terms of viral suppression? Quickly, there was no overall significant effect of financial incentives at the financial incentive sites versus non-standard of care. No effect was noticed by community. However, we did see a significant effect at the sites that had lower baseline viral suppression. And we also saw a trend at smaller sites and a significant effect at hospital-based sites. Now, when we looked at the peak of the intervention, when we had a chance for these sites to take on the intervention, we did see a significant effect of financial incentives in terms of increasing viral suppression at sites compared to standard of care. A trend at Washington, D.C., a significant effect again with financial incentives at sites with lower viral suppression at baseline and at smaller sites as well. There was another interesting finding, was a significant effect of financial incentives on continuity of care, again, demonstrating an important impact of this intervention. So what are the lessons learned quickly? I think we demonstrated it was feasible to use financial incentives for linkage to care and viral suppression at scale. It is not easy to do financial incentive studies. There are lots of concerns people have about utilizing money to incentivize behaviors. So we had to overcome a lot of concerns by providers, by patients, by community groups. So that took a lot of time, but it is doable. And you need to engage a lot of stakeholders. In addition, you of course need to also engage them in terms of understanding their concerns as well. We developed a qualitative studies, and these are several posters we put together to try to understand how these sites and how these patients felt about the financial incentives. And overall, there was high acceptability of the intervention, but there were some concerns by some providers that you should not be incentivizing people to do a behavior they should already be doing. The other lesson learned was that measuring outcomes via a surveillance system is feasible, but it requires a lot of strengthening of the surveillance system. This was done in collaboration with the study and the CDC and the departments of health. And we also needed to take into account certain characteristics of the reporting system. For example, the data are reported by laboratories based on an individual's jurisdiction of residence rather than site of care. So when you're doing a site randomized study, it's very hard to link the individual to the site of care rather than to the jurisdiction where they live. The surveillance system in the US, does that have any information on ART use, for example, which is very fundamental when you're doing a site randomization? And lastly, the availability of site data in the surveillance system is not routinely available or not looked at in that manner. So for example, in the data, we're getting labs from financial incentive sites and lab from standard of care sites, but of course we did not know the proportion of people who were on treatment in either of these sites because that data on ART is not available. There were other lessons learned that are important. One, I think, was one of the major findings from our study is that potentially the need for targeting the financial incentives. We provided financial incentives to everybody who was virologically suppressed, even if they were at baseline at that site. But we did not see a significant effect. However, we did see a significant effect of financial incentive at sites that had certain characteristics, like I said, again, lower viral suppression at baseline and hospital-based sites. So it makes us think that maybe one should target financial incentives in the future, in future studies, rather than using them across the board. We also, as I mentioned, provided financial incentives to all the patients who were virologically suppressed versus targeting those who actually were unsuppressed. And there are data from other research using financial incentives that indicates that you should target these incentives and you'll get a more significant effect rather than giving it to all the target population. And then, of course, the complexity of using site randomization versus individual randomization, which is often the case and much more pragmatic in the context of trying to use financial incentives. Lastly, types of lessons learned is when to expect the effect of financial incentives, particularly at a site or at a community level when you're using this kind of design. And I think it's important, what we learned is that you need to give sufficient time. We saw an effect at the peak of the intervention, and you need to give enough time to reach saturation at those sites or in those communities to be able to actually, and then measure the effect of your intervention. And then we also, the other question that arose is what are the other possible effects of financial incentives? We did see an increase in continuity of care as evidenced by regular clinic visits, and there may be a use for such incentives to enable better retention, and thus we can tackle other comorbidities or other health threats that these patients may face. So lastly, in conclusion, we believe that financial incentives offer promise for achieving desired health behaviors and health outcomes, and that continued efforts are needed to study, to do more research and more innovation in the use of these incentives and in identifying ways to measure their effects. And lastly, something important to keep in mind that we should always aim for pragmatic research designs so that the findings from studies can be replicated and in particular implemented at scale. I want to acknowledge everybody who participated in the study, particularly the team and the departments of health in the participating communities, the CDC, and many investigators, patients, and our community advisory group. Thank you very much.